just going to, oh, yeah, I do have some other roles, I guess, pertinent to this outside of the Marsden. So nationally, I have the privilege of chairing the Stereotactic Radiotherapy Consortium. On a European level, I'm currently chairing the ESTRO, which is the European Radiotherapy Society, the ESTRO Guideline Writing Committee, which is not just lungs, that's quite scary, covering all radiotherapy guidelines, whether it's breast, you know, whatever. And then internationally, in the IASLC, which is the International Lung Cancer Organization, I currently chair the Advanced Radiotherapy Committee. So lots of busy roles, quite varied and very, very interesting. Okay, great. All right, so just going to run through the topic of the evening, which is the role of radiotherapy in mutation positive non-small cell lung cancer. But before I delve into that, I started training in oncology as a registrar, which is back in sort of 2001. This is really where the role of radiotherapy sat in metastatic lung cancer. We had very poor drugs, very poor survival. It was non-small cell lung cancer was all one disease, and radiotherapy was reserved purely for palliation. And I'm pleased to say that it looks nothing like this today, as many of you are aware. So the biggest change has been the transformational change we've seen in systemic anti-cancer therapy. And you will all know out there that one of the biggest advances has been the introduction of immunotherapy, with one of the early keynote trials there demonstrating the benefits over and above traditional chemotherapy. But also pertinent to this group is that genomic medicine is now considered standard of care. And it seems like every week we are getting a new mutation that in a few months is followed by new targeted agents and new lines of therapy potentially coming out over time. For example, the first line osimertinib compared to earlier TKIs shown here in the FLORA trial. So alongside of that, the other thing I think that's changed is that we've got much better imaging than we ever had back when I first started training, far more sensitive at picking up smaller lesions. And because patients are firstly living longer, and because they've got potential for more lines of therapy than we ever had before, they're being monitored very closely with imaging, because number one, are they still responding to that line of treatment? But also, if they're not, it needs to be picked up early because they've got other options. So we're seeing many more imaging time points than we ever have before, and with more sensitive imaging. And the reason that's important is because that's where these new patterns of disease that we keep describing keep raising their head in multidisciplinary team meetings. So the other kind of concept I wanted to kind of discuss is that although mutation positive advanced lung cancer is a systemic disease, it's in the system, and therefore the systemic drugs are always going to be the mainstay of therapy. But what we're trying to do here is look where, well, if it's a local problem at any one time point, can we use local therapy to add to the underlying systemic therapy for, gains in outcome? And then not just the role of radiotherapy, but specifically in a number of the trials of SBRT, where does this now fit in? We've got more modern techniques in radiotherapy that are highly conformal, allowing us to deliver high doses safely to small targets. So how does this all fit in to the current paradigm, which is changing quickly in the world of the disease and the drugs? And I'm just going to spend a bit of time on this slide, because I think this is where a lot of confusion lies, not just with patients, but quite frankly, with my medical oncology colleagues. So I'm just going to go through these 4 scenarios, which are all pertinent to the trials. So when we talk about oligo anything, oligo is from the Greek word meaning few. So it's talking about when we've only got a few lesions, the disease burden is not kind of widespread, lots of areas of disease. Now, the first one I want to talk about is what we call synchronous oligometastatic disease. And that's where we have metastases, but they're only a few, and we find them synchronously, so at the same time as we find the primary problem. So you see the primary illustrated in can you see my arrow at all? Is that moving around for you? So this is the primary here. And at the time of diagnosis, the primary is active and there's 2 sites of metastatic disease. So that's synchronous oligometastatic disease. Now, the next one I want to discuss is similar. It's called metachronous oligometastatic disease, otherwise known as oligorecurrence. And that's when somebody has been diagnosed with radically treatable, potentially curative disease, has had treatment, and then with an interval, with no therapy, a disease-free interval, then unfortunately relapses, but only does so in an oligo pattern. So doesn't relapse with 20 sites of disease, only relapses with limited metastases, okay? Then these 2 really come into play when we're talking about mutation-positive lung cancer, and it's really because these patterns arise on systemic anti-cancer therapy. And that's because patients are on tyrosine kinase inhibitor long-term. It's not like you get 5 cycles and then we stop, like with chemotherapy or whatever. Because you're staying on that drug, we see other patterns emerge. So oligopersistence, the word induced is just there because it's induced by the drug. Okay, so however many disease sites you start with, if you get a good response to that tyrosine kinase inhibitor and you're on that treatment, at the point of best response, you may find that everything has disappeared except 1 or 2 lesions, and that's known as oligopersistence. And then the other scenario is what we call oligoprogression, and that's when however many sites of disease you've had up front, as long as you've had a response initially to the drug, which could have gone through oligopersistence, but not necessarily, at the point of progression, rather than everything losing control, we only see progression in a limited number of sites, known as oligoprogression. So all of these 4 are kind of distinct patterns at distinct time points. And it could be that any one patient has all of these, or in any one journey through the lines of therapy, they may never have synchronous oligometastatic disease, or metachronous or oligopersistence, and only have oligoprogression, or any one of the combination of these things. Okay, so all of these patterns really matter when it comes to the trials and the levels of evidence when we're looking at the role of radiotherapy. So the kind of thing, so that the word palliative radiotherapy, I think increasingly, I personally think we should be dropping, because it confuses a lot of people, because palliative radiotherapy means you're using it to palliate symptoms, and quite often these lesions are not symptomatic. So that phrase disease-modifying radiotherapy, we can't call it curative. That's not what we're able to do. But disease-modifying implies we're trying to help in the modification of the disease over time to improve outcomes without it being needed for symptoms. And the kind of rationale behind a lot of the trials is, can we use the radiotherapy to help prevent metastases seeding new ones? Can we help it eliminate potential subclones of disease that are starting to get resistant to an otherwise working drug? And possibly more so outside of the mutation-positive patients, can we help it to stimulate that immune response we see with immunotherapy? So those are the kind of concept and rationales for a lot of the studies out there. And I've kind of covered this. So this is, the journey of any one patient. Up front, you may have synchronous or metachronous at the point of diagnosis, but then at any point, where would you consider in any one patient's journey whether there's a role for radiation or a role for a trial by adding in a local therapy? So first of all, I'm going to go through some of the data we've got, evidence supporting radiotherapy in synchronous oligometastatic disease. Now, the first trial to report was a number of years ago now. It's tyrosine kinase inhibitors were around, but only the early generations, and immunotherapy was not around. Now, this included any patient with oligometastatic disease with non-small cell lung cancer. It did include a handful of patients with mutation-positive disease, but the majority were unknown or didn't have them. And it randomized patients to either systemic therapy alone or after the initial 4 cycles of chemotherapy, addition of local ablative radiotherapy or not, followed by maintenance, depending on availability or a physician choice. Now, the local consolidation or the local treatment was not purely radiotherapy. There was also options for surgery. And this study had an update in 2018 demonstrating not only a median progression-free survival, but also an overall survival. Now, there are a few caveats to the study. It was only 49 patients. It was a phase 2 that was stopped early, and it was stopped early by the Independent Data Monitoring Committee, who felt it was unethical to continue because the curves were separating so much. So it is a level of evidence, but it's not as high as we would like to see. And clearly now we've got immunotherapy and we've got third generation TKIs and hardly any patients with mutations in that patient population. We really need more data, not just to prove that it's still efficacious, but also that it's still safe. So those are the two things. You know, what's the payoff? How much benefit do we get for what cost? In terms of toxicity. More recently, and this has only come out in publication this year, although it was presented in the pandemic at ASCO initially, is the SINDAS trial. So this is synchronous oligometastatic presentation, specifically in patients with an EGFR mutation. So they had limited burden of disease upfront when they were diagnosed. I think they were allowed up to 5 metastases and the primary plus or minus lymph nodes, but only a maximum of 2 in any one organ. So they could have had 2 liver mets, 2 bone mets, and a adrenal metastasis, for example. And these patients were randomized either to tyrosine kinase inhibitor alone or the addition of local ablative therapy. And it was a bigger study, about just over 60 in each arm. And again, this was stopped early by the Independent Data Monitoring Committee at the interim results because of the separation of curves. So only phase 2, not phase 3, but still, you know, important data, again demonstrating median progression-free survival and median overall survival in favor of addition of the local therapy. So again, very important, although, you know, these are relatively rare patients because unfortunately the majority when they present don't have limited sites of metastatic disease, but nevertheless an important study. Okay, so then we have the SARON trial. Now I've put this in, although it specifically isn't for mutation positive patients, partly because of some of the questions that came in earlier. So the SARON trial is very like the original GOMEZ study, looking at adding in radiotherapy to all sites of disease in those that present with synchronous oligometastatic disease. We're allowing up to 5 lesions, unlike the GOMEZ original study, which was 3 lesions. We are excluding patients who have mutations because essentially it's now considered a different disease and it would need its own trial like the SINDAS trial. And it was felt it was very much a different question to what we've got in the SARON trial. And the SARON trial is really looking at bigger numbers than the GOMEZ study in the era of immunotherapy. We have now 103 out of 134 randomized patients, so hoping to get some results for this patient population soon. There's a similar study running in the States called LU002, which is currently finished its phase 2 bit and is being analysed to see whether it can go on to a phase 3 or whether it gets stopped early depending on what the results are. But the aim across the pond with the SARON trial is, regardless, is to pool the data and then do a meta-analysis of this rich data set. Moving on to metachronous oligometastatic disease. So the COMET study was the first randomized study to report in this setting. Patients who've had their primary treated, has not come back, but when they relapse, they do so in 5 or fewer sites. Now, this study was very heterogeneous, very pragmatic. So you could have any cancer. You could have breast cancer, prostate cancer. It didn't matter about mutations or hormone status. It was an all-comers metachronous oligometastatic disease. Again, in the chemotherapy era, so before immunotherapy came along, randomized either to drugs alone or drugs plus stereotactic radiotherapy. Again, updated at ASTRO 2018, median progression-free survival and median overall survival advantage with the addition of local ablative treatment. And then an update just last weekend at ESTRO, now with data going out to 8 years, albeit with small numbers, no new additional safety concerns. And I'm just got to remind myself, that was hidden by my face. No impact on quality of life by the addition of the radiotherapy. And they noted reduced rates of subsequent need for palliative radiotherapy from 70% down to 24%. And although overall the rates of subsequent drugs were similar, there was a lower rate of subsequent kind of old-fashioned chemotherapy. But again, very heterogeneous. But on the basis of this trial, we do have stereotactic radiotherapy in metachronous disease commissioned routinely. So we don't have a trial in this setting in the country because it's now considered standard of care. We'd still like more data, and David Palmer and the team over in Canada are now running 2 studies. So although COMET allowed up to 5 lesions, in reality, the vast majority of patients in the study had up to 3 lesions. So they said, we can't draw any conclusions about those with 4 or 5, because although they were allowed in, we just didn't see any going in. So which is why the phase 3 studies are called COMET 3, which is up to 3 lesions, getting more numbers. Again, very heterogeneous. Any cancer, you know, can go in. We can ablate them all. And then the other one is a very ambitious COMET 10, which allows any patient with 4 to 10 oligometastatic lesions to go in. So again, looking at whether, because again, there was a question earlier, so I put this slide back in saying, well, why can't we treat lots and lots of bits? So this is really looking at whether, is it safe to go that high, and is it diminishing returns? As in, the more you have, is it truly oligo, or is it, you know, such a systemic disease that it's not adding anything to outcome and just causing side effects, potentially even limiting the ability to give systemic anti-cancer therapy. So 2 very interesting studies, both recruiting well in Canada. And then particularly pertinent to this group are these patterns that we see on these longer term drugs, which is the oligo-persistent and the oligo-progressive disease. So an interesting study called CURB. Now, as many of you are aware, I run a study called the HALT study, which I'll come on to in a second. I developed it kind of in parallel with David Palmer, who was developing one in Canada. We've discussed so many aspects of the study, but one thing we never discussed was the name of the study. And it was by complete accident that I called mine HALT and he called his STOP. So this one was the 3rd one to come through, but has recruited and reported first. And they went with the theme and went for CURB. So this is, if you know HALT, this is like HALT in the sense that it's oligoprogression on systemic cancer. So regardless of how many sites of disease you've had up front, as long as you've had a good response, at the point of progression, if it's only limited progression, you get randomized to the addition of stereotactic radiotherapy or not. Now, they included patients with non-small cell lung cancer and patients with breast cancer. And the non-small cell lung cancer, you could be mutation positive, but you could also be mutation negative on chemo IO or IO alone. And this was presented at ASCO back in September, October last year. And the interesting thing was they did see a progression-free survival advantage. Oh, sorry, I need to move on to the next slide. The progression-free survival advantage was purely in the lung cohort. So if you separated out the breast, there was no advantage at all seen. Median progression-free survival, 18 versus 17 weeks. But in the lung population, a big difference in the progression-free survival with an astounding hazard ratio, albeit phase 2 small numbers. But if you look at it here, this is interesting. More than 75% had more than 1 lesion, which is good in the sense that if it's all 1 lesion, it doesn't tell you about a higher burden of disease. 54% had immunotherapy as part of their treatment, but only 14% of these 14% of the 58 patients in the lung cohort had a driver mutation. So whether this is purely an immune phenomenon that we're seeing here, because the vast majority may be PD-L1, have on 50% of them were on immunotherapy, or whether it's being diluted because there is or isn't an effect in the driving mutation positive population, we don't know. So not only was this presented at ASTRO, but it was also presented recently at AACR in April, just gone. And both times they highlighted the need for a study dedicated to mutation positive patients in this setting, because we need more data. Enter stage right, the HALT study, which many of you know about, and some of you may even have taken part in. So the HALT study is specific to mutation positive non-small cell lung cancer, where we've got a driver mutation in patients who initially respond to that drug. It doesn't matter whether you're on first line, second line, third line. And we didn't want to make this a pure EGFR study, because the kind of concept of these subclones is the same. The kind of biological rationale is the same, regardless of what your driver mutation is. And we knew we were never going to have one study for ROS, one for ALK, one for EGFR. So it's all together being stratified by the mutation type. And at the point of progression, if it is oligoprogression, which is up to 5 lesions, they're randomized, and we've weighted the randomization towards the experimental arm 2-to-1. So for every 2 patients that we add in the stereo, 1 patient doesn't get the stereo added in, which is the standard of care arm. And we have, so this was updated 2 weeks ago. I think we may have 1 more randomized. So I think we may be on 78 out of 110 patients randomized. And we're fortunate enough that this trial was also adopted by the EORTC. And you can see the sites there in Europe that have also opened up and are helping recruit to this study. So the STOP trial is the Canadian version, and true to Canadian style is much more mixed bag. So they did start in non-small cell lung cancer, but all non-small cell, mutation positive or not. And they struggled to recruit. So they made the decision a few years ago now just to open it up to all oligoprogression, breast cancer, prostate cancer, whatever cancer you've got. They have now completed recruitment, and they are awaiting the endpoint analysis depending on events. So hopefully we'll get some results from this study at some point in the next possibly 12 months. For oligopersistence, there's less work, less trials out there. I think the main one is the North Star trial, which is run out of MD Anderson. So I think this is any EGFR mutation positive patient at diagnosis who is going on to first line osimertinib. As long as they respond to the first 6 to 12 weeks of the drug, they get randomized to either carrying on with the osimertinib or having the radiotherapy added in. Now, not all of these patients will be oligopersistent as opposed to kind of any persistence. They're stratifying between those patients who've got 3 or fewer lesions, which is a true oligopersistent cohort, and then the others, which is kind of clinician discretion as to how many lesions you treat. So there'll be some with induced oligopersistence and some with induced persistence, but still a very interesting study. I think it's drug company sponsored, which is why it's specifically osimertinib and why it's tied therefore to EGFR rather than other mutation types. But so more data will come from that. Just a couple of other slides I added in at the end just to consider, particularly because of the value of patient and public involvement in the design of these trials. I think, there's missing a bit of my slide. I must not have saved it properly. So I always use this slide when we're talking about trial design to say, what endpoint is the most crucial endpoint? Do we always need to demonstrate overall survival for a trial to be worthwhile? Progression-free survival does come with a lot of caveats, partly interpretation of imaging. It's difficult to interpret imaging when you've introduced radiotherapy because of all of the scarring the radiotherapy causes. So you have to have independent review to make it a meaningful endpoint. Should we consider studies where quality of life is the primary endpoint? One of the ones I've missed out here is, should we be looking at freedom from new disease? So if you've only got 3 METs, is it an important endpoint that's not waiting as long as overall survival, saying, well, they were free from new sites of disease for however many months? Should we be looking at whether it improves overall response rate to the systemic anti-cancer therapy, and how relevant is an endpoint if we can defer the next line of systemic anti-cancer therapy, defer the need to change to a next line of therapy? And then the box that I added in, which has jumped away, basically said, you know, what do we consider is necessary for the funding of these indications in the UK? Does it always have to be OS or PFS? And how, as a community, can we influence what, you know, we feel are strong enough endpoints for change in commissioning? And then again, I put these slides in after looking at the questions earlier. A question kind of around, why can't we just kind of irradiate everything? Why does it have to be limited to 5 or fewer? Again, this is another rationale. Can we use radiotherapy to reduce disease burden? So the old-fashioned, what we call the Norton-Simon hypothesis was, well, the more you reduce the disease burden, potentially by using things like radiotherapy, does that help the systemic drugs work better because it's working on less burden of disease? So revisiting that is being done, and it's mostly in the kind of immunotherapy type patients where immune stimulation is important, because disease burden seems to be linked to your ability to mount an immune response. There's some biological data to suggest that. So one of the very bold studies in Canada, which I just thought I'd mention, it's a bit out there, it's only a phase 1. It's called the ARREST trial, arresting disease. So it's phase 1, so it's looking at how safe is this as an approach rather than looking at efficacy yet. And it's looking at how many lesions can we treat. If we literally try and irradiate everything, what does that look like from a toxicity viewpoint? You know, in the modern era with stereotactic radiotherapy, keeping dose to normal tissue structures as low as possible. And so they are starting to look at this. You know, the Canadians are being very bold here, looking at it. And I'm not quite sure where that's going to go, depending how feasible it is and how safe it is. But studies like that are beginning to emerge. And that's really all I was going to formally do with slides, but happy to, you know, have a chat and generally take questions, if that's all right. If I go out of stop share. There we go.
Okay, that's excellent. Thank you very much, Fiona. Very, very interesting. And in fact, you've answered some of the questions that we got through earlier on. Deb, do you want to go first and go through some of the questions that came in prior to today from your ALK colleague?
Let me come off mute. Right. Okay. Yeah. So one of the questions that came from our group was, are there areas that cannot have radiotherapy? And the reason for asking this is this particular member said, my pleural lining is thickened and the tumour there is where I had recent recurrence, as well as another nodule that showed growth. I've had an explanation as to why I can't be in the HALT trial, but would like to understand more on this.
Yeah, so there's a few reasons. So I think there's 2 separate questions in there. One is, what can you and can't you treat with radiotherapy? And then separate to that is the kind of fairly strict HALT trial criteria, because trials are very kind of strict in their approach. So the kind of lesions you can't, and it also depends what you mean by can you treat with radiotherapy, because obviously there's varying degrees of radiotherapy from the truly palliative all the way up to the very, very high doses of stereo with sort of traditional radical about here and high dose palliative about here. So there's a whole spectrum, and it comes down to the size and location of the lesion and how close you are to normal tissue structures. So when you're talking about stereotactic radiotherapy, you're talking about a small lesion, traditionally 5 centimeters or fewer, although we have introduced up to 7 centimeters within the HALT trial. And it's got to be away from normal tissue structures, so much so that you can get the ablative dose in without overdosing something critical. So we are limited, particularly, for example, a lesion that's near small bowel. What we don't want to do is give an ablative dose that's highly likely to control that lesion locally and leave a patient with a high risk of bowel perforation, knowing that in the context of metastatic disease, if you're then in hospital having an operation for bowel surgery, the other disease, you know, other sites could be running away and you're not fit enough for your next line of standard of care because you've taken too much risk controlling one lesion. So there are lesions we just say it's just not safe. We wouldn't be able to get in an ablative dose. And if it's not ablative, you know, why are we doing this? We reserve any radiation for the true old-fashioned palliation if it causes trouble. Specific to pleura, so pleura is interesting. So the pleural cavity is the whole cavity around your lung. You know, it's a whole lining of the lung. So the cavity is quite big. And one of the concerns with pleural disease is that it's never truly isolated. And that by the time it's in the pleura, it's kind of all around there. It's the same issue we have with treating mesothelioma with radiotherapy. You can't cover an extent of disease without overdosing the lung and other structures, because it's kind of so widespread. Even though it's very thin, it tends to be very thin. So I suspect the disease, as far as Holt, it's either more than 7 centimeters or it's just kind of diffuse thickening, which is just not targetable safely with a stereo dose. It doesn't mean you can't have any radiotherapy, probably, if it were to cause symptoms, but it wouldn't be in the stereo kind of end of the spectrum. It'd be lower down at the, you know, let's try and help with symptoms type thing. Is that kind of, does that kind of cover it a bit?
Yeah, I think so. Yeah. From what I've heard, yeah, I would agree. So, Angela, do you want to do an EGFR question, or?
You carry on. You do the other.
Oh, okay then. All right. So, so another one of our members wrote, I have a progressive neurological condition and I'm always worried about being written off when it comes to trials. What's the criteria for being accepted for HALT? And is it only done at certain hospitals?
So we wouldn't specifically exclude someone on the basis of a neurological condition. It comes down to, you know, general fitness. It comes down to the pattern and extent of disease, including the size and geographical location of the lesions. And it comes down, you need to have demonstrated response initially. So it's not a study looking at what we call primary progression on the drug. So patients who never responded to the drug. The whole point is that we're trying to extend the time you benefit. So we're not looking at patients who never benefited anyway and are progress at their first time point. There is an issue with brain lesions as part of the disease. So we initially, when we opened the study, said, well, because stereo is already commissioned for limited brain disease, historically, because that was all explored years ago, because it was always considered this sanctuary site from chemo, and therefore it was a question asked years ago when it was just chemo, you know, can radiotherapy help where the chemo can't get? So because that was an old question answered a while ago, that's commissioned. And therefore, we initially excluded patients who couldn't have stereo to the brain, as in it was so widespread, the disease, they didn't have that stereo as an option, they had to have whole brain. But we since realized, particularly with the newer generation of TKIs, is you can get amazing control in the brain, despite only ever having had, you know, palliative treatment with whole brain radiotherapy. But so we introduced an amendment to the study saying you need to have controlled disease in the brain for a certain number of months before we say, right, we're happy that the brain is not going to be the issue. And therefore it's reasonable to ask the question about, because it's only oligo in the rest of the body. So yeah, it is a fairly, much like any trial, there are fairly strict eligibility criteria, but we've tried to make them as inclusive as possible within the realms of safety, knowing that that's part of the issue that we're trying to explore in the study. When it comes to where's it available, I don't think any clinical trial is available in any centre up and down the country, and that really comes down to resources, and that's trial resources. So the money we get from our Supporter Cancer Research UK only has got a finite amount of money, so we can only open it in a certain number of centres. It's also to do with local setup. So you need to, you know, any local team has to have a generally active research community, research nurse, data managers, the whole kind of setup locally to be able to open it. So I think we are quite fortunate that we're fairly widespread with HALT, but it's certainly not in every centre. We're certainly much better off now than we were when it initially opened, and potentially just after the pandemic, when some centres were very slow to reopen because of pressures. But travel is an issue. Travel for patients going to a centre that's not close to them is unfortunately not funded. It's not something that Cancer Research UK fund. So in the early days, we had patients referred from Cambridge and Birmingham down to the Marsden. One of the things we were exploring is support for travel for patients who were travelling to, via the Roy Castle Foundation, for example. So it is an issue, but it shouldn't preclude you being offered a study locally. Sorry, as in offered referral, if that's something that you would like. We're happy to take patients from afar, not just at the Marsden, at all of the Holt centres.
Okay, and finally, from here from the out group is, could I have radiation done privately if I didn't get on the trial? If unable to get on a trial, are we able to access the same treatment through compassionate use? So they're two actually different questions.
So if the question is about if you're not eligible for the trial, then if you're not eligible for the trial, it kind of depends why you're not eligible as to whether there's actually an indication for radiotherapy, and therefore whether you could or couldn't access it privately. But if you didn't want to go on the trial because you didn't want the element of randomization, then you can seek the experimental arm privately. The reason I still, have equipoise, although I do offer it to my private patients, having been through the international data. My concern with going ahead with the approach is the data that's out there. So this approach originally started in a couple of small case series in the States where they didn't randomise, they just took patients with oligoprogression, and they added in the stereotactic radiotherapy, and then they followed them and they did quite well. And that really is the level of evidence that's out there. The trouble is what they were comparing it to, because it's not randomized, these studies were kind of comparing to the outcome of patients who didn't oligoprogress. So you have patients with widespread progression and you have patients with indolent progression. And then you add in radiotherapy and you assume it's the radiotherapy that's made the difference. Well, if you hadn't added in radiotherapy, they'd have done better anyway because they've got indolent progression. So you can't compare fast or widespread progression with slow or limited progression and then be surprised that they do better. So there is a real, the scenario that Holt could be negative. It could show that we've wasted patients' time and added toxicity for absolute minimal benefit. Or it may be that it shows what, the rest of the world will then turn around and say, well, that was obvious. Why did you run a trial? So, but you just don't know until you try. And, rightly or wrongly, the UK are very heavily evidence-based, and I've been brought up in a very heavily evidence-based medical world. And I'm probably speaking to the wrong group when I say an advantage about the UK is because it's not commissioned until we've got the evidence, we are strong at being able to recruit to studies. And the rest of the world, in all honesty, just look at CURB being presented in America twice this year. The rest of the world are looking to us to answer this question because everyone else has lost equipoise, really on the basis of very little data on efficacy and safety. But, if you want to seek the treatment privately, it's out there. And, and in the States and in Australia and in most of Europe, this would be considered standard of care. But on the basis that we can't, no one can say, well, if we add in the radiotherapy, you get on average 4 additional months on the drug or a year additional benefit on the drug. And no one can promise, that it's definitely safe. You say the COMET had, deaths on trial. So we can't pretend that everything is safe, and we really need trial data to back it up, because that's what you guys ultimately, ask of us. Why are you doing this? What will the benefit be, and what's the risk? And that's why I think the trial's important. And bearing in mind how well we've recruited so far, if we get this finished, if it's negative, that's really important to know that we should potentially be sparing toxicity. And if it's positive, we will get this commissioned.
Brilliant.
Okay, thank you. Thanks, Fiona.
Thanks, Deb. Thank you, Fiona. A couple of questions from our group. The first one makes me very sad. Should I be worried that my oncologist hasn't heard of the HALT trial or the Mariposa 2? He did mention SARON, which you've also mentioned, that's coming soon. I'm at a hospital without another one close by. Should I be concerned that I am missing out on options for trials and possibly other treatments?
Do you know, it's a heartbreaking question to listen to, and I'm not sure I can give a helpful answer other than to say that's just very sad that there's a centre in the UK that have not heard of the HALT trial, and that are even unaware that SARON is not for mutation positive patients. So, every oncologist is required to do continuous medical education and achieve a certain number of points every year in demonstrating they're attending educational events to keep up to date. So that is worrying that, the HALT trial's not new. It's been open since 2017, I think, 2018. If they were saying we're just struggling to reopen it after COVID, or we're a small centre, but we know where our LinkedIn centre is, wherever. I mean, there's so many, like, just off the top of my head, Ipswich, they don't have a massive trial community, but they've referred so many patients for HALT. And I mean, there's so many centres that don't have it open, but they're aware of it and they're advertising it. And this is, I've had these conversations with Deborah and Angela. This is where I think you guys as a group, or as the two groups, are so strong in your patient voice. If things really are that bad in the UK, despite us trying to present it at every educational event, having, all of our sub-PIs say, please advertise it to your region and all the rest of it. If the situation really is that bad, the patient voice becomes so much more important in, the empowered patient going in and said, what about the HALT trial? What about the SARON trial? What about trials? Where's the nearest trial centre where I can go and discuss options? And whether that's, radiation studies or additional drug studies, I think it's hugely concerning, Angela, if I'm honest.
Yeah, I agree. And the only thing that pleases me about that question is that the individual knew about the HALT trial and the Mariposa trial. So they were able to bring it up and talk about it. So that's a tiny positive and a really... Absolutely.
And it's why, these groups, you guys all supporting each other and educating each other. And, it only takes one of you to know where to look, to signpost, one other member. And hopefully this will change. We'll carry on. Sanjay's always giving me time at BTOG to advertise these studies along with all the other studies. We're constantly having trial updates, but the clinicians locally have to engage and sign up to these educational events. And whether that's partly because of COVID and people have been limited in their ability to take leave to attend conferences, but as I say, HALT's been around long before COVID.
Yeah, disappointing. Is there a link between the HALT trial, SARON trial, we now know isn't relevant for us, but what about the RAMON trial?
So,
is it RAMON?
Yeah. You're recording, so I'll be careful with my words. RAMON is SARON.
Ah, right. Okay.
It's just, but it includes surgery. So my personal favoured approach would have been to add in. So SARON predates me. The original PI of SARON unfortunately became unwell. So I took it on in 2018 as the replacement chief investigator. But when it was originally designed a few years before that, we didn't have surgical community buy-in. To be able to have surgery as an option. We couldn't rally the surgical troops, is my understanding, but that predates me. So when there was renewed surgical interest in this question, my preferred approach would be simply to amend SARON and add in surgery. But instead, there's a separate study which is not yet open, addressing the question that hopefully SARON will answer.
Right, okay. I think we can hear what's underneath your thinking in relation to that. You very kindly showed us a couple of slides which showed that trials were stopped early for very positive reasons.
Yeah.
When that happens, has there been sufficient evidence gathered for the treatment to be approved? Or what happens next?
So this is one of the problems we've got. So an independent data monitoring committee is entirely independent from the investigators, rightly so. And they look out for very important things like safety signals. So if there's lots of early deaths in the experimental arm, they just shut it and say it is not safe to carry on answering this question. And if they see an early separation of the curves, they come off the fence and say, well, it's not ethical to continue this study because we have got an early signal that this is positive. The problem is that you're then left with limited data on really knowing what the outcome is. So it weakens the result because you've stopped early. And where that might be enough data to change insurance companies who fund treatment in the States, is that enough data to change commissioning via NICE? And this is the problem we've got. You know, we can't influence the American Independent Data Monitoring Committees, but we know that 49 patients is never going to change a commissioning decision in the UK. So it's another reason for us to run the, robust studies over here and with our European colleagues. So it is an issue, but it's the reality of the trial world we live in.
Mm-hmm. Okay. And the final one is a bit not quite what you're talking about, but I think people will be interested. We're hearing a lot about artificial intelligence at the moment that reads chest x-rays or interprets imaging without oversight from a radiologist. One has recently got clearance in Europe. What's your view on this?
Well, it's not my area of expertise. I heavily rely on my radiology colleagues to tease out all of these different patterns of disease. But, you know, AI, my understanding is that it's a very strong tool. And as long as it's been through robust validation processes, then I can only see it as being, a good thing. Because one of the biggest issues we've got in the UK at the moment is radiology reporting times. Mm-hmm. So, if you have a scan, at the Marsden, we're very lucky. I've always been able to get scan results within 1 or 2 days, and I appreciate I work in an ivory tower. But with COVID and the struggles and the backlog we've had, we have seen that extend to possibly a week at the Marsden, and it's not infrequently in the last 3 or 4 months I've had to phone patients and say, I'm terribly sorry, I haven't got your scan result. And I'm so used to having it very quickly. But in DGHs, the problem's been, really quite severe, like, weeks to get a scan result. So if with all of these additional imaging time points I was discussing, every patient now being scanned, they're living longer, they've got more lines of treatment, you want to know whether you're still responding. If you're not responding, you want to know so you can change treatment because you've got other lines to move on to. With all of these additional imaging time points, the resource is becoming scarce. And if we can use AI to fill that gap, I can only see it as a good thing. But again, caveat, not my area of expertise at all.
Okay. Thank you very much. That's all the questions I have. Lizzie, have any come in on the chat?
Yes, I've had one on the chat. Question is, what is BLU, BLU 945?
Google. BLU 945. Is it a trial? Here we go. Robust clinical activity in preclinical EGFR positive, 4th generation TKI. I have no idea. That's a medical oncology question.
Right.
But it looks like just from Google, it looks like it may be another potential promising line of treatment for EGFR in the 4th generation.
Okay, that's excellent. So that's kind of a positive place to end, really, isn't it? would like to say thank you, Fiona, from all of us. I'll hand over to Deb in a minute to say her personal thanks, but on behalf of the EGFR group, thrilled that HALT is happening. Cross our fingers it all goes well for you. And thank you so much. Really, really appreciate your time. For everybody listening, we will get this on both the ALK and the EGFR positive websites in very short order. So Deb, what would you like to say in closing?
I'd just like to say thank you very much indeed. I think everyone will have picked up something. I've learned something new tonight, definitely. So thank you very much. And yeah, we will continue to encourage any of our members with progression to discuss the HALT trial with their oncologist. So we will be advocates for HALT going forward, or we have been, because yes, you know, we've come across stories equally of oncologists not being aware of it, and so it's important that we're all talking about it all the time.
That's really helpful. We're so close. We're so close to getting a good answer with a good amount of data, you know, around this very specific question, and all your help is gratefully received.
Okay.
Thank you very much.
Thank you very much, Fiona. Thank you everyone for attending.
Thank you.
And we'll have the next one soon. Take care. Bye-bye.